I'm happy to be with you. I'm covering research science in Montreal. I'm a freelance reporter, but I also work for a television program on Télé-Québec. It's a public television program. I just wanted to tell you this quick story while you're sitting down, is that we usually at the end of the program have a discussion about new research, and I'm usually the last one to raise the question, but what about disparities in healthcare in this particular issue? And one of the last discussions we had was on the techniques of resuscitate someone after a heart attack. And so the numbers, the figures, the disparity, depending on where you are, if this happens to you, is tremendous. It could be 20% if you're in a hospital, close to a hospital, but if you're in a region where there's no healthcare service, it's 3% chance of being brought back to life. So that's one example. But I'm sure you have several questions for our guests, and we actually covered a wide range of issues that are related to disparities right now, whether it be regional, cultural, and we're happy to take your questions. We have Patrick in the back and Alexandra who are going to distribute the microphones. And perhaps what we could do is actually start with Dr. Shapiro, who had a question at the end of the last session. Dr. Connor Shapiro, you had a specific question? It's paused.
I got an answer from the speaker in the break, please.
Right. Dr. Angel, you have a question.
This part of the program is dedicated to solutions. And so I'd like to ask each of the debaters, in a way, to identify two recommendations that they each would make of their highest priority in terms of intervention. I know that there are multiple, deal with the entire, but your personal priorities based on your areas of interest. What would you recommend? Two for each.
The question of who wants to go first.
Okay, I'll try. The two I would do, one is much more emphasis on appropriateness than we've done, because more is not always better. And to get care that you don't need can be 0 for 2. It's costing a lot of money and making you worse. So I would like much more attention to appropriateness. The second is I would like to tweak the funding formula so that funding is, comprehensiveness and insured service are based on care that is needed and important for people rather than who's giving it and where. So that, pharmacare is one of the big things that we have not addressed. If we're talking mental health, how much of an issue is it that somebody with a mental health problem can't afford their meds? If they don't have pharmacare, how do they pay for their meds? And if they relapse, that is your classic penny wise, pound foolish. But if they don't need the meds, they shouldn't be getting them.
Well, that's a very important, if I could just debate that second point. Appropriateness is easily understood by society. But tweaking funding formula is not understood. Could you simplify that?
Simplify it the way both Kirby and Romano did it, which is that if you need particular care, it should be paid for, and it shouldn't be a function of who delivers it or where. It should be that if you need that care, you get it no matter where you happen to get it.
Good, thanks.
Yeah, but you guys haven't.
Yeah, we haven't had. Do you want to go, Andrew, or shall I?
I'll go. Dr. Bell.
I would, of course, the first area I would always say is research, investment in continuing to understand who's out there, what they're doing, conditions of work, and finally, of course, how effective are they. The second part that I've become interested in is highly functioning teams, healthcare teams. We have a very traditional view of what a healthcare team is. And as I mentioned before, these teams are changing now. There are new players, new actors. And how much do we've spent a lot of money trying to understand interprofessional teams, but we haven't really given a close look to what a highly functioning team is. And I mean that from a variety of perspectives. including the patient or the recipient of care, I think we'd be quite surprised to find who a recipient might find to be the most highly functioning. From a research point of view, that's challenging. It's hard to study satisfaction and perspectives, but I still think that's an area we need to look at, and we need to redefine what a healthcare team is.
I guess you're saying that it's a forever moving target to trying to define disparities in the workforce, right? And there has to be ongoing research. Dr. Newbold, you have a
Yeah,
answer?
my two thoughts there. One, integration of services. So I certainly, I talked about this idea of one-stop shopping for new arrivals in particular, but that could be extended to certainly a broader population. But that integration also to encompass different government roles and the different jurisdictional levels in terms of government, to make sure that the dialogue and the discussion continues between the local municipalities or municipalities and provincial government and up to the federal government. I think the second piece, and it really sort of stands in juxtaposition to the first comment around integration of government roles, but the role of the local community and the idea of mentoring there. And there's certainly multiple examples, at least from Hamilton and I'm sure other communities, where individuals have been trained to be lay providers, and they've gone out into the community and talked about the importance, say, of breast cancer screening, of mental health care, and we've seen tremendous success with those programs, and then the funding disappears. That's a different question, but they give the examples and the insights about what role those mentoring roles, or the opportunities for those mentoring roles, and what they can accomplish.
But do you have a feeling that we're actually getting better than we were 10 years ago?
Yeah, in terms of sort of a timeline, I'm not sure.
In terms of engagement from the
Yeah, in
community?
terms of engagement, because what I've seen oftentimes is that these programs and mentoring opportunities come and go because they reflect sort of the flavor of the day, or where funding is available for something to take off. They pilot it for a while and then the funding dries up for it. There's that need for the long-term sustainability of these types of programs and to make sure that they continue to grow. The appetite is certainly there for those mentoring type of programs. It's the continuity that's the problem.
That is lacking. We have a question, Patrick. If you would please stand up, introduce yourself. Thank you.
Introduce myself. My name is Matthew. I'm just a first-year medical student at the University of Toronto. Thank you very much for all your talks. I wanted to talk about tweaking the funding for healthcare, and a lot of you brought up good points with integrating teams, interprofessional teams, but that takes time, and time with all the research that would go along with it. And I think one of you were saying about something about psychiatric care and providing what they need and giving the funding for that. But I find a lot of people will talk about that we should put funding towards here and we should put funding towards here. But where are we getting this funding from? Where are we taking it from? You can't just make money. So what services are we overfunding now, and where are you trying to get this money from?
That's the efficiency argument. More efficient.
Where this gets tricky is the whole one size does not fit all, because what makes sense for one patient may not necessarily make sense for others. One of the things that they are tending to do is to download the funding to providers who are responsible for that full patient. So the whole idea with primary health teams is you have primary health teams with a whole lot of different resources there, and they can pull together what you need for that individual patient. And in a number of cases, you can be win-win, that you're spending less money for better outcomes, which is, I would say, it's what they keep trying to do. You see the back and forth on home care, which is your job to keep people out of the hospital? Is your job to keep people at home? Is your job to keep people out of nursing homes? And the mix of services you give is going to vary with that. And that's why I made that point about who's going to pay for what. Because in the veterans program, one of the things that was really important to keeping people at home was having somebody come and shovel the snow. Now, is that a government role, or should you be setting up the local community that the teenager next door should be coming and helping out shovel the snow, or, having, the neighbors? So how do you make sure that people can get in and out? My late mother-in-law managed really well at home because she didn't just have this family around. There was a local fruit store and things that delivered. So they delivered food, and all of a sudden she has this informal network that can make things work. So I don't think it's as much this idea that you need more money. I think in a lot of cases you need less money, you need less pharmaceuticals, you need less of some of these things, but you have to figure out what it is that's going to, another neat study, and I'm talking too much, is that they did some studies, Janet Lum at Ryerson did some studies of social housing. And she found enormous savings of all things in 911 calls. Because if you had somebody at the front desk that you could call if you had a problem, you didn't need to call 911. So all of a sudden, by having one staff member there, you didn't need to make the calls to 911. So I think it's go to the family, go to the providers and say, what do you need to make this thing work? If you can work with a diabetic about how to and then here's where the cultural thing comes in. If you come from an ethnic group, it doesn't help you to give you the information on what the white bread North American should be doing as a diabetic diet. You need to take the diabetic diet and tailor it to what people would actually be eating. Now, you don't have to do that in every single thing. So if the Diabetes Society or some others would get together and say, okay, here's a good East Indian diabetic diet that we can be giving the information on. So it's just figuring out what do you need to do to have the person thrive. And my suspicion is it's going to be cheaper.
Right. And God knows that our Indigenous people are particularly affected by diabetes and lack of services where they are in remote areas. We have
to get food,
We have 3 questions. Alexandra?
Properly introduce myself at the beginning. I'm Alex, and I'm a second-year PhD student in nursing. And so my question is actually going to the piece around, clearly one of the big themes that is resonating with, I think, all of the speakers is the role of the social determinants of health. And my question is, perhaps maybe going back to the 20,000-foot view, how do we and what policy levers perhaps can be used to better integrate health and social services, for example, in Ontario? And then I guess a second part to that is how can we as clinicians or as citizens really help to support or push those types of levers forward so that we can have a much better, to your point, Bruce, around the integration, a much better integrated both health and social services.
One of the things, the public health departments have been trying to do just that, is to integrate the health and social services. The population health theory now has been known for quite some time, and I think the public health units really responded to that. They began to realize that obviously there were determinants that, and I think Bruce said that there's a lot more to the story than health. But one of the issues that what we've also seen is what we call, at least I call, pop-up solutions to integration. And I believe that we should work within the system with what we have and work with efficiencies. But what tends to be the response now by governments is what a pop-up solution. So what's a pop-up solution are these health links, for example. This is supposed to integrate care for you. And when I first heard of it, I thought, that's interesting. It's highly variable. You have to apply for the funding. It turns out that different regions have created some interesting innovations. Supposedly, if these innovations are so unique, they'll stand the test of time. Guaranteed they probably won't, because I think it's one-time funding, or it's not recurrent over time. It's probably an additional budgetary item on the health budget. Or as Reza said, it may have come out of another envelope and taken the funding away from something else and put it into something else. This type of planning is quite chaotic, and it's really, really difficult for clients to understand. I know, I can just imagine Dr. Sinha's clients when they try to understand what is a health link. Oh, this health link is for you, it's supposed to make things more integrated, you just phone this one number. It's not clear. So I think around integration, clarity of what the services are to the population we try it, but I don't think we do a good enough job. The population really has to understand what they have the right to sort of deserve and what they can comment on. And I feel that's a missing link because the healthcare system has become so complicated. And we know this from a research point of view. I mean, it was a lot simpler and to a certain extent cheaper. Things have become more complicated. We are living longer, and you heard from Reza, maybe that doesn't cost us that much money. That was refreshing. But the thing is that we need to be more efficient. We need to understand our system, and we should not be increasing the amount of money over time we invest. We should be getting more value from the existing dollars. I'll just end with one note. The fully functioning team issue is one that began, is there anybody out there who's sort of fully functioning and feels that when we went to hospitals to do the pilot study, we'd go to the senior managers, can you identify your fully functioning teams? They didn't even spend 2 seconds. They knew right away. In a very large hospital, what ward? They know. People know what works, and at least that's what it demonstrated to me. They didn't say, I have to go and talk to so-and-so and so-and-so. They know groups that are working together. They're working efficiently, effectively, high patient satisfaction. Those are the criteria. So all I'm saying, there are good things out there, and we have to replicate them, and we should not be adding to them.
Two other points or thoughts, and it goes stepping beyond sort of the healthcare realm. But policy, when you ask about policy levers or places that could use improvement, housing as one, and so the need for stable, affordable, appropriate housing, across the population, not being, just immigrant specific. But, certainly Hamilton housing, for example, Toronto public housing, providing that. But, we see examples where families are broken up because the housing is too expensive or does not have enough room in it to accommodate the family. And then that brings in the whole role of social isolation and networks once again. It's removing that family or diminishing the role of the family in terms of providing support. The other piece, again, non-health, but certainly related through social determinants, is the role of employment. And employment recognition or credentialism, making sure that, again, people have access to employment. And part of that then is engaging employers to make sure that opportunities are provided for the experience and decent wages and so on.
To talk again on determinants of health, there's a couple of interesting success stories. I'll give you one is automobile accidents. We changed the rules around cars in terms of the crash safety, air quality in terms of what the emissions could be for cars, which makes a difference in that. Seat belts, talking on cell phone. Don Redelmeyer finds that people talking on cell phones is not a good idea. Next thing you know, you get some of those. So here's an example where totally non-health things have made a big difference in health. Another one is food labeling. If you want to now see how much sodium is in foods or things like that. Fire safety, the fact that things are not going to, the sofas are not going to catch on fire and burn you with that. Mental health employment is another key one. Is there some work that we can do to take people with mental health problems and actually help them get jobs and use their potential?
These are important determinants for sure, social, economic determinants. But we have to let's bring us back to our focus of healthcare.
What I think that the point we're trying to make is the focus should not just be healthcare, because the best thing you can do is not get sick in the first place. So if I can figure out how you don't need to have great access to care to repair you from an accident because you didn't have the accident, because the seatbelt kept you from getting killed, I think that's probably good.
I agree with you. We don't have a single Canadian healthcare system. We have 11 provincial and a couple of territorial systems.
11? Which is the new province?
I think it's a province now.
What?
Territory.
Isn't Nunavik a province now?
No, I think it's still a
Territory.
territory.
Territorial
Yeah.
systems.
Yeah.
But I also agree that we have to, it's not just healthcare, we have to go beyond that to the social determinants. I wonder if we can learn from our provincial counterparts. For example, coming back to your one-stop shopping, Dr. Newbold, the province of Quebec has this CLSC, which my French does not allow me to say fluently.
That's right. CLSC.
Centre
right.
Local Social Communautaire, whatever. And of course, Alberta had regional health authorities. They used to have 6, and now they downsized to 1 at the Ministry of Health. Why are we dealing with 14 LHINs in Ontario where regionalization of healthcare has not been shown to work? That's a rhetorical question.
You don't have it.
I can give
can
you one. The part of the thing was in terms of the issue of private delivery. Do you wipe out individual hospital boards and throw them into a quasi-national health service like an English model, where you no longer have the autonomy for the individual hospitals? And there's been incredible variability across the provinces in the extent to which you left power with individual hospital boards or moved it in. I like to tease my friends from Alberta, which is the only place in Canada which has moved towards socialized medicine, is the People's Republic of Alberta. But Ontario very deliberately decided that they wanted to keep individual hospital boards, keep the donors, keep everything else, keep the local communities happy, because if you try to coordinate, the local communities got very up in arms. So you do have unbelievable variability across the country in the power they left with the individual hospital boards as opposed to moving them to the regional health authorities, also in which services you put into the regional health authorities and which you don't. And yeah, you're right, there's pluses and minuses, and that's why they vary in what they do.
Yes, we have a question in the back.
I'm Jesse Cancer, a student here at the University of Toronto. Thank you for the presentations. A comment and a question. First comment is just to remind everybody that we in fact have 14 systems in Canada, right? We have 10 provinces, 3 territories, and the Canadian system, which is often overlooked, but is one of the largest systems because we do take care of Aboriginals, inmates, and our armed forces.
Yes.
So there's definitely a role at the federal level for healthcare. That's an aside. The question really is, I guess my interest is in the role of agents in system transformation or in solutions, and I think about physicians a lot. And the one thing that comes to mind, I mean, in reading last night about healthcare change in Saskatchewan, I mean, the physicians were not on board, right? We talk about physicians who are very opposed to probably the best thing this country has seen, according to Canadians, right? In naming Tommy Douglas the best Canadian. And I think of now physicians through something like the Canadian Medical Association, the faculties of medicine, the Royal Colleges, explicitly using the term leader to define physicians. Now, I'd like to get the opinion of the panel on that. And I know we have at least one medical student here. What would your word be to medical students who are really looking to transform systems? Is there a danger in physicians being in charge of that? And if not, what really should be aware of when we're trying to make those system transformations?
I'll just start. And it goes beyond physicians. I think this is an evolution, partly to, again, to involve governments, you know, to work with governments. You see many health professionals. The physician lobby is really strong, followed very quickly by the nursing lobby, which is strong. The difficulty is they become lobbyists for their profession rather than the lobbyists for healthcare. Mm-hmm. And I don't think there's very many health professionals who feel comfortable with that role, but they do it. And they get an existential angst about it, right? Because they've actually really believe at the beginning they're there to care for people. And then they find themselves heavy into these professional lobbies. And it's a protective mechanism. It's when it's fundamental, probably social scientists, when you're under threat or you feel you're under threat, that's that fight flight, and they come out, with their papers and their briefs. So I was on the OMA, the website just last night, and then I went on to the CNA website, and it's just interesting, all the solutions are there, and they all fall within those professional groups. And again, individuals are not like this. It's more of a group lobby effort, and I don't think it reflects well on us. I think we have to step back. The leadership has to step back and try to encourage to move away from that professional lobby and to look at issues of care and become perhaps a little more altruistic, and that's really where you get, your feelings of satisfaction, to tell you the truth. And that's a big step, because educators are the worst. We also educate students to be lobbyists. So it has to start with the education system to a certain extent and be brought over to the practice system. And that's just my comment on issues of lobbyists within professions.
I think Andrea said everything that I was thinking of. We certainly train our students, whether social scientists, health professionals, whoever. We train them to be leaders. We want them to be leaders. We want you to be leaders here. But the point being, and again, you said it better than what I am, to play together. It's a sandbox out there, and we want everybody to play there. And I think that's is lost oftentimes, that you sort of divide off that sandbox, go back to your disciplinary pillars, silos, and you play there without reaching out.
That's a very humble and noble admission to admit that you have to go back to the basic of your training. Do you agree?
I agree with everything said. An additional thing is you have to look at the funding models, because the last thing you want to have is incent people to practice bad care. And fortunately, most clinicians are sufficiently honorable people that they don't do it. But you don't want to have them feel like suckers, that the ones who do the best are the ones who are least ethical. So I think another one of the reasons why I am such a big advocate of looking at the appropriateness and doing it with clinicians, because they know what seems to make sense, is to say you don't want to have the funding formula misaligned with what's going to be the best practice of care. And how do you do it in a way that you don't incent for? That's why I don't like all this activity-based stuff, because you don't want to incent people to do things that don't need to get done.
We have a question in the back.
Hi, so again, like others, I would like to thank you for coming and for giving these talks. As someone who doesn't know a lot about these issues, it's been really educational. So I guess throughout the afternoon, I'm getting, I guess, a sense that, and please correct me if I'm wrong, is that we're getting to a stage that we're pretty good at identifying sources of disparity. We're, but pretty good at quantifying, measuring the impact of disparities, and fairly united they should be addressed. So there's and Dave Goldman said, but the caveat is more research needs to be done. So my question, I guess, is, with this wealth of information about the sources, impact of disparities, and potentially solutions to them, how efficiently is that wealth of information being translated into action? And what are, just briefly, maybe some barriers to that? And if you can identify, is there like some interventions that say the academic community agrees are good and should be implemented, but are for some reason not implemented?
It's a great last question. To wrap it up, how would you summarize?
I'd say one of the problems comes into ideology and people's sense of values. If you watch the debate in the United States over the Affordable Care Act, the main argument against it is, why should I pay for you? If you're poor and you're sick, you're obviously an inferior person to me, because I am, a wonderful person, and why should I have to pay for you? And you can't debate that. I mean, you sort of can say, okay, if somebody's got contagious tuberculosis, you might be at risk of getting it. But the sense of empathy and realization that we're all in the same boat and we should be working together is something that is ideological and ethical, and I have found very alarming the extent to which we've given up on the idea that we should be helping each other. All of this, tax cuts, we shouldn't have to pay, no gravy train. I mean, what is a gravy train in a lot of cases, other than helping people who need some help. And if I don't need a lot of health care, I say, thank you. I'm happy I don't need it. I don't have a problem paying for you if you're sick. The fact that I don't have any young kids in school doesn't mean that I shouldn't have to pay for other people's kids. So I think, to me, the biggest problem we have around this disparity is it's turned into some idea that if you're poor, it's your own fault and we shouldn't be helping you. You know, the job creators versus the moochers. And somehow we have to get beyond that dialogue to recognize that we're a community.
Your comment reflects a comment that I heard the director of CIHR make about a year ago, saying we can identify the disparities, we can identify barriers. Now we need to move to the solutions. How do we overcome them? And there's certainly a research, and there's certainly a host of best practices that are out there and that can be utilized and copied and shared across space. The problem is we're not always good in terms of sharing that information. You know, maybe the best practices or these examples are done by small grassroots organizations or small communities that don't have the expertise or the ability to share them, translate them further afield. CIHR, if you apply for funding there, they certainly want to know how you're going to take your research and then translate that into the broader community to make sure that that information is shared. But that's only one piece of what happens in the community on a day-to-day basis, that translation of research. But there's other examples that could also use that same sort of sharing so that we can deal with some of these disparities.
Do you have one last word to Dr. Bauman?
That's probably the most difficult question, saved for the end, right? But just to agree what's been said, but again, there are cheaper alternatives for effective care. So I think we always have to look at the best way to do things, and sometimes it isn't with the fancy hospital care issue. We love hospitals in Canada. If you try to downsize a hospital or make it smaller and move it into the community, take a part of that dollar, whoa, the public just, down in Niagara, they're building another new hospital. I mean, do they need one? No, they tried to do an urgent care. Whoa, that community. It's a lot of public education, but you see, again, that's us, the public. We have to educate the public that, for example, hospitals may not be the way to have the most effective care. We have case studies of Denmark, Sweden, very good home care, people cared for in the home. We don't have institutional housing of the elderly, et cetera, and so forth, that we're moving towards in North America. So there are alternatives, but I think, again, health professionals and higher education, like universities and colleges, have a role to also influence community with information. And it's not all about spending more money and having fancy buildings and more technology and more drugs. It's sometimes the solution is housing. I know CAMH, for years CAMH has lobbied hard for decent housing for the mentally ill. That would go a long way. They do need the medication, et cetera, but they need housing, and they don't have it. And it's only getting, in my opinion, just observing, it's getting worse. If I go downtown Toronto, I see more homeless. So the solutions in some ways are a little bit radical. You've got to step out of the box, you have to be brave, and you have to give something up.
So
Something probably status or whatever.
So no, not necessarily more money, but more compassion and
Yeah.
more talks. I guess symposiums like this help to think things through and find solutions.